I'd like to welcome everybody to the HCC Connect Summit. You know, this year, for those of you who attended the previous two Liver Connects, or one of the two, the format was very different. It was more of a lecture format. And because the attendees wanted more of a summit type of a presentation format, that's why we changed it this year. And it's actually been very good because we've been able to really have good focused discussions for people that have interest. And that's what we're going to do this afternoon with HCC. We have a very, very diverse and rich panel that are going to present for you various topics of interest within hepatocellular carcinoma. And at the end, we're going to have two very pertinent interactive case presentations that will be presented by my co-moderator, Dr. Wong, to the panelists, and you'll hear what approaches they take to problems that you see every day. And then there will be a question and answer session at the end before we conclude. I'd like to introduce my co-moderator, Dr. Robert Wong, who is a clinical associate professor of medicine at Stanford. And thank you, Robert, for coming. Dr. Robert Gish, who many of you know too, who has had just such an impact in the field of hepatology in general over the years, a tireless worker, who's at St. Joseph's Hospital and Medical Center now in San Diego, and the head of Robert Gish Consultants. And the last two panelists, Dr. Neil Mehta, who's a transplant hepatologist and the medical director, of liver transplantation, of living donor liver transplantation, and an associate clinical professor at UCSF. And lastly, Dr. Richard Finn, who will give us a little bit of a different viewpoint because he is a professor of medicine, but in hematology, oncology at the Geffen School of Medicine at UCLA. So first, I'd like to call up Dr. Wong and discuss with us updates in HCC epidemiology and care cascade recommendations. Robert.
Great. Thanks, Dr. Flam, and thanks for having me start this HCC Connect session off. As Dr. Flam mentioned, we have a great line of speakers, and hopefully it'll generate a lot of great discussion. So keep your questions coming. As you saw, you can either ask your questions live or submit them, and we'll definitely have a few sessions for Q&A coming up. So I'm going to start the session just talking a little bit about HCC epidemiology, talking about the care cascade, and a little bit about disparities that precede HCC that ultimately lead to downstream disparities in HCC, and how we can address some of those disparities with quality improvement programs. So those are the objectives there. First, I'm going to talk about the burden of liver disease. I think it's important first to understand the scope of the problem. As many of you know, globally, liver disease accounts for over 2 million deaths per year, 1 million due to cirrhosis-related complications, about 1 million due to viral hepatitis and liver cancer, HCC. Cirrhosis and liver cancer account for 3.5% of all deaths worldwide. And WHO flips from 2 to 3, but liver cancer is about the third leading cause of cancer-related deaths globally. What about in the US? In the US, liver disease cirrhosis accounts for over 52,000 deaths per year. It's the 12th leading cause of death in the US. HCC is the 5th leading cause of cancer deaths in the US. And despite improvements in screening, diagnosis, treatments, overall 5-year HCC survival is still less than 30%. So a lot of room for improvement. Understanding gaps and disparities that precede HCC can identify potential opportunities for targeted interventions in how we can improve the entire cascade of care that ultimately lead to improvements in HCC outcomes. In many ways, for the HCC cascade, poor clinical outcomes can be preventable. And what I mean by that, how can we identify and address potentially modifiable factors and gaps in care along the cascade? How can we improve early detection, timely access to effective therapies for all patients? And how can we use what we learn through problem assessments and implement early intervention through education, prevention, targeting both patients and providers? Socioeconomically disadvantaged and vulnerable populations in particular experience the majority of healthcare disparities. And that's important because these compound existing inequities that these individuals and populations face. And some examples here that given in the parentheses. And so the goal is, how do I identify potential low-hanging fruits or easy gaps that we can develop quick implementable change to really address some of those barriers and challenges that lead to poor outcomes? I like to think about this cascade often because it really highlights the entire cascade. While we're focusing a lot on the downstream outcomes of HCC cirrhosis, liver-related morbidity and mortality, it's important to remember the upstream cascade. And this starts as early as screening for liver diseases, screening for Hep B, screening for Hep C, linking those into effective care, monitoring access to treatments, assessing response to treatments, identifying those who need HCC screening and getting them appropriate and timely screening for early identification and plugging them into treatment. So when we think about improving disparities and improving outcomes in HCC, we really need to think also on opportunities upstream where we can bridge and fix some of the existing gaps in care. And trying to think about what are those barriers, there's no one easy answer and no one easy fix. These factors can be simplified in some ways into three big buckets. This is not completely inclusive of everything, but we can think about some of the potential patient factors, what are the provider factors, and what are the health system factors that ultimately contribute to some of these gaps and disparities. And really, there's no one answer, and really any solution that attempts to address some of these barriers really needs to think comprehensively about addressing multiple factors and individualize it to what are the main issues and problems that are challenging your patient or challenging your health system. Oops. This is another paper that was published recently that also emphasizes not just thinking about the upstream cascade, but thinking about what are the social determinants of health. Again, we focus a lot on downstream outcomes, which are important, but thinking about what are the upstream factors that we may not think about or may not think carefully enough about that are affecting the patient sitting in front of us, and how can we think outside the box and really address some of these factors comprehensively to really bridge and improve outcomes downstream. So I'm going to use Hep C and Hep B as two examples on how upstream disparities really leads to downstream disparities in HCC outcomes. This is one study looking at several, I think 4 safety net hospitals that included about 30,000 chronic Hep C patients. As you can see here, pretty diverse population. And despite the availability of DAAs, you can see that while treatment improved, only about 17%, at least by the end of that study, were treated with DAAs. There were significant disparities among certain groups seen, not just race, ethnicity specific disparities, but also disparities by payer type. And so definitely highlights some of the underserved groups and high risk groups that are really not getting timely access to treatment. Following on that, these are other similar studies. This was one big study published a couple years ago looking at the Florida Medicaid claims data and saw similar things amongst about 14,000 chronic Hep C patients. After the approval and availability of DAAs, we saw increases in Hep C therapy, but there still remain significant gaps. And at the end of this time period, in about 2018, only 8% of that Florida Medicaid program population received DA therapies. Another aspect that they looked at were which are certain groups that were disproportionately affected. This study observed that patients that were co-infected with HIV or had concurrent substance use were much less likely to receive Hep C treatment. And as with other studies in this Florida Medicaid population, they also observed significant disparities by race, ethnicity. These are two other studies to also highlight different high-risk groups that are disproportionately not getting treatments. On the top graph here, this is a study, again, looking at multi-centered safety net population to look at the impact of concurrent mental health or substance use disorders. And as they illustrated, those that had concurrent mental health or substance use were about 40% less likely to receive Hep C treatment. And then on the bottom graph or bottom figure here, this was a large data set using the national VA data, about 134,000 chronic Hep C patients through 2020. And they observed that patients that had a past or present history of alcohol use based on audit C score were also less likely to receive treatment, about 25% less likely to undergo Hep C therapies. Moving on to hepatitis B and the Hep B cascade. Many of us have seen this and the big gaps here, the huge population we know about worldwide. And then as you look at who are actually diagnosed, a big gap there. And then amongst those that are estimated to be treatment eligible to those that are actually receiving antiviral therapy, another big gap. So big opportunities and disparities in treating Hep B that then potentially lead to disease progression and risk of HCC downstream. These are a few studies to highlight. From Hep B, we think about screening, linkage to care, ultimately treatment to identify where those gaps are. This is a little bit of an older study, but it really highlights the same message that we're not doing a good job with screening. And this morning we heard at a different session disparities and the big work that we need to do to improve hepatitis B screening. Luckily, there are new recommendations now for universal Hep B screening, but the challenges remain: how do we implement those? And how do we improve upon these very low rates of screening? In this particular study, less than 40% of those that probably should be screened for hepatitis B, only less than 40% were screened. Linkage to care. Screening is the first step, but that's not the end step. Screening, the point of screening is early diagnosis so that you can then link these individuals into care and treatment. This is a single-centered safety net hospital looking at Hep B patients that were followed in the GI clinic. And we were trying to identify what were the rates of successful linkage to care, which is defined as first-time visits, and then what were the proportion of those that were retained. One visit is good, but if you drop off afterwards, you don't get the necessary monitoring, assessment for treatment eligibility, and care that is needed. Overall, you see less than 70% of patients were linked to care. But more interestingly, of those that were linked to care, there was another drop-off. Less than 70% of those ultimately were retained into care beyond the initial linkage. We saw some disparities there. I think the most important one to highlight, which all of us know and makes clinical sense, those that had an assigned primary care provider were much more likely to be linked and retained into care. And that makes sense because that in many ways is a surrogate of engagement. These are people plugged into care, have access, are engaged, and henceforth are more likely to be retained and followed in hepatitis B care as well. What about treatment? So screening, linkage, getting them to treatment is really the important last step. This is a multi-centered, I think, four safety net hospital, over 5,000 chronic Hep B patients. Unfortunately, we saw that when assessing the proportion of treatment eligible patients, and when we say treatment eligible, we were using ASLD criteria at the time, of those that were eligible, less than 50% were treated. Even more concerningly, if you look at those that did not have HIV, only about 37% of treatment-eligible monoinfected chronic Hep B patients received antiviral therapy. We also saw some disparities by sex, race, ethnicity, as well as language, which is perhaps a surrogate for other socioeconomic factors. Similar data from a different population. This is national VA data from a few years back, but also observed similar gaps and follow-ups in the cascade of care. In this study, they had about 21,000 Hep B patients that were identified, mostly men because it's the VA population, but you can see here the demographic distribution. Overall, you can see on the figure, many patients had, of those that were diagnosed had ALT testing. But when we look at some of the other downstream parameters, such as who had DNA testing, who were assessed for treatment, who actually received treatments, you see a big drop off. And this is where it creates an opportunity. How can we bridge this gap and bring some of these bars back up to ensure that patients are being assessed for treatment eligibility, people are getting monitoring that is appropriate for chronic hepatitis B, and ultimately get plugged into antiviral therapy to reduce long-term risk of HCC. So these, as we show these, the overall declining incidence of Hep C-related HCC has been observed, and many of this is due to the advent and availability of cure regimens. However, in parallel, we've seen the increasing burden of NASH-related HCC as a large population of patients with fatty liver are aging and developing liver-related complications such as cirrhosis and HCC. And as we mentioned in the earlier slides, the sobering statistic is, despite all the improvements that we've achieved with HCC, overall survival remains only at about 30, overall 5-year survival remains at about 30% still. These are the most recent, some of the more recent data published just last year in hepatology, looking at the NCI-SEER data and looked at differences or trends in HCC incidence and mortality. And as we've known and seen, that HCC incidence and mortality looks to have peaked at around 2015 and has started to decline. But we continue to see persistent race ethnicity specific disparities. And some of these disparities, while it's hard to identify specifically in some of these large data sets, some of these trends may reflect improvements in the treatments of viral hepatitis. But as we mentioned, also the emergence of NASH and potentially alcohol-related liver disease and HCC. We also have seen trends when thinking about those on the transplant list. These are data from the UNOS OPTN data. On the top graph here, you can see that when thinking about etiology of HCC in patients awaiting liver transplants in the US, the red line represents those with Hep C, and you can see the drastic decline in Hep C-related HCC to the point where NASH is likely to, or already has probably overtaken HCC on the wait list. And the bottom figure is a different way of looking at it, the proportional increase compared to year 2002. And what is striking here is you see in the green line representing those with NASH-related HCC, in which many of us see in our clinical practice as well. HCC screening and surveillance is important. That's important because screening and surveillance is perhaps the most important part of the HCC cascade. Early detection, early stage tumor allows patients to get potentially curative therapy. This was a systematic review and meta-analysis published a couple years ago of 29 studies and estimated another sobering statistic. Pooled estimates of appropriate HCC surveillance among cirrhosis patients was 24%. We've also seen important disparities with ethnic minorities less likely to receive HCC screening and surveillance. And because of that, that has translated into more advanced and aggressive HCC at presentation and subsequently less likely to receive potentially curative therapies. And these are tables from some of these papers emphasizing the race ethnicity specific differences, with African Americans and Hispanics more likely to have advanced or distant or disease beyond the Lawn criteria. And then in the table on the right, these same ethnic minority groups less likely to receive curative treatment, but also any treatment for HCC, despite adjusting for potential confounders. Effective HCC surveillance is perhaps one of the most important steps in the early HCC cascade. As I said earlier, it leads to earlier tumor stage. Tumor stage correlates with likelihoods of receiving potentially curative therapy and long-term outcomes. Understanding and addressing these disparities in surveillance is important to reduce downstream disparities in outcomes and survival. But it's a very complex interplay between patient, provider, and system level factors. And really any solution that tries to address these really needs to incorporate the gaps in each of these paradigms to develop effective solutions. This is, if you'd like to check out, this is a tool that we developed on the CLDF HCC subcommittee. We worked for almost a year, it seems like, with the group of our advisors, and we developed a digital interactive tool. And this is widely available now, primarily targeted to primary care providers, but can also be targeted or use trainees, GI, any providers. And the goal is to help aid as a patient support tool, help educate and guide individuals, and guide providers on identifying who's appropriate for screening, how do you interpret screening, what is the follow-up, help guide them through staging, and then ultimately some brief summary recommendations about treatment. But we didn't get too detailed with treatment because, as we'll hear in some of the subsequent talks, that it can be quite nuanced depending on the situation. So definitely check it out. I will share just a few brief screenshots from the algorithm. This is on the CLDF website. These are some screenshots from what it looks like. You can plug in your patient information, go through the algorithm, and this is sort of the complex map behind the algorithm where you go through the decision of cirrhosis, what is the etiology, what is what are their risk factors, do they need screening, ultimately assessing their LIRADS criteria, what is recommendation based on the LIRADS score. Those that are diagnosed with HCC based on BCLC criteria, we were able to incorporate those recommendations into some early summary recommendations that can really improve the provider, but also help improve the patient's understanding about their disease stage and treatment options. So really, I'll end with that. Then take-home points, HCC remains a leading cause of cancer-related morbidity and mortality in the US and globally. Disparities in timely diagnosis of upstream chronic liver disease can contribute to downstream HCC outcomes. Gaps in disparities in timely screening and surveillance for HCC is one of the major important disparities that we need to address to improve HCC outcomes. And novel interventions are needed to improve HCC care cascade and to improve long-term outcomes. And I want to thank, these are members of our HCC committee that worked on this and developed this over the past year. So thanks to those members. And that's it. I'll move it to Dr. Gish.
Robert, I really want to thank you for using the word surveillance throughout your talk too. You know, that's one of my sticking points. When people use the word screening, like patients say, I've been screened, then they think they're done. Or like colonoscopy every 10 years. But surveillance really gives people a powerful message about repeat testing. And I'm going to talk about biomarkers, both current and future. And I'm going to give you some strong opinions about what I think should be happening right now, pending more research, of course, but what you can do in your practice today with our current data. I do want to update you that said St. Joseph's on my affiliations list. That was when I was working in Arizona, I think, although I do work for a St. Joseph's Hospital in Santa Rosa, but I have 5 clinics where I see patients. One's federal, one's rural, and then 3 private practices where I'm the hepatologist that's embedded in these different groups. And I get to look across all these different types of insurance scenarios, including one in San Jose where one of the insurance companies doesn't want to pay for biomarkers. They even push back on AFP, which drives me crazy. So we are convinced now that early detection of liver cancer is associated with improved survival. And this is a SEER database. But if you look at data from Asia, especially from Japan, this curve that goes out 5+ years has a 50% survival rate. And I'm going to talk a little bit more about Japan and how they do surveillance when I'm building in this discussion about the biomarkers that we have available for us today. This is also a meta-analysis up through 2014 talking about early detection works. We're likely to receive curative therapy, improved overall survival. So I don't think there's any argument about early detection. Now the question is about how do we get there? We have quality improvement needs in terms of surveillance. It says screening here, but it's really interval of surveillance, and it's all over the place. So this has to do, I think, with lack of patient education, instability in insurance systems. In the federal clinic in San Diego where I work, we have a large hepatitis C population we've looked at over the last 5 years, and we had to test and treat relatively rapid, although we have all these barriers that were in place until recently from Medi-Cal. So we lost half the hepatitis C patients because by the time we got them in through the pre-auth process, they were gone. They had moved on to a different clinic, a different location. And I see the same problem with liver cancer surveillance that's there. So this is a short list of candidate HCC biomarkers as well as current. AFPL3 was FDA cleared in 2006. And I was at the meeting where the FDA team member was there in Princeton. We have a Princeton meeting related to hepatitis B and liver cancer that dated back 2 decades. And they said, yes, AFPL3 and AFP are now FDA cleared to work together. This is now the standard by which all future biomarkers will be used. They were approved as risk markers, not for diagnosis. That's super important to communicate that. And I think it was 2011 when DCP was FDA cleared. You remember, you used the word cleared for diagnostic tests and approved for therapeutic tests. So we've had these tools for a long time, and there's data on DCP, formerly known as PIVKA2, dating back 3 decades. The Japanese have been using this triple biomarker panel since the 1990s, and that plus compulsive ultrasound surveillance has pushed them to the best survival for HCC patients in the world. Just think 50% 5-year survival. There's been some really good research also about integrating biomarkers with callbacks, outreach, clinical reminders, EMR triggers, et cetera. And of course, this is going to improve access to care. So I think we really have to think about this in a very dynamic way, which Robert Wong just reviewed. I'm now going to bring up this GALAD score, which I have been committed to for close to 10 years. When I was working with Philip Johnston, when he was bringing all of his data forward, both from the Asia and the global database that he built using this these 3 biomarkers. And this was just absolutely compelling to me, looking about sensitivity and specificity of these tests. And they are used not just for current diagnosis, because really diagnosis is made by imaging, but current risk. If you got a negative imaging, you have a positive GALAD score with a risk for HCC that's at what you think is a clinically significant level, or I think is clinically significant. We have enough information to act on this now. I know there's lots of research going on. There's a large prospective study that's taking place in the US at this time with these biomarkers. But I think this data is compelling enough that we can use this today in our practice. All of these biomarkers are available through LabCorp, Quest, ARIP, Mayo Clinic. We have data act today, especially we know how bad our outcomes are for early detection using ultrasound alone or ultrasound plus AFP. So I think this data remains very compelling. This is a relatively small number of patients with controls, cirrhosis, chronic hepatitis B, showing these very high AUCs for the GALAD score compared to ultrasound, statistically significant, and I propose to you this is clinically significant. More data, not affected by ascites, sorry about the misspelling, or child Pew score. And then we're using this GALAD in combination with ultrasound, which I think is the real world experience. I think we, again, have really good data that we can be using this in our practice now. Yes, we always love more research, but you have to at some point in your life say, in your practice, say, we have enough data to act now, especially when we have, I think, reasonably valid information. We make lots of decisions based on meta-analyses. This is a meta-analysis about GALAD score, looking across different diagnostic groups, different geographic regions, BCLC scores, early stage. Again, compelling information that this is useful in our clinic today. So what I found in medicine, there's human behavior is strange sometimes. Starting 20 some years ago, we had many providers, advisors, guidances, review articles recommending that you vaccinate a patient who's hepatitis B core antibody positive because the test had a high false positive rate. But there was never any data published that vaccinating a patient who was core antibody positive had any clinical benefit. Yet hundreds of providers, tens of thousands of patients got vaccinated when they were core antibody positive. And when that started happening over 2 decades ago, the data starting in 2002 was that the core antibody test had a very low false positive rate, 1 in 500. This is Roche data that was submitted to the FDA in 2002, Abbott data. Yet for 2 decades, we're still vaccinating core positive patients with no data. I claim now that the GALAD score is the inverse of that situation, and GALAD plus ultrasound is our best tool today for early detection of HCC. And early detection has to do with changing your current behavior, but also changing your near-term behavior. What are you going to use for surveillance? Are you going to move from ultrasound to MR scan? And now we have, of course, these short MR scans also that are showing substantial benefit. But today I'm going to be talking about biomarkers, not too much about imaging. There's some really good data that's coming out about using these surveillance biomarkers as a bridge to liver transplant. I'm not going to go through all the details here, but I know Neil's here and we can definitely talk about that maybe during the debate and the panel. I think these are very useful. I see patients every week have a normal AFP, but have a high L3 and HCC. So we detected it early and we know which biomarker to follow. I also have had patients with normal AFP and L3, high DCP, early detection, and we use the DCP to help follow and manage those patients. I think these are useful, not just in that early detection setting, but also in ongoing management with good data here. And if you're triple negative, much better outcomes than if you have 2 or 3 of these biomarkers positive. So this is, I think there's very good information to be using this clinically also, even in the transplant setting. I think the GALAD score is very easy. Go online, you have MD Calc, you have these 3 tests. 3 tests cost about $200 for a cash pay patient. It's under that, of course, from an insurance perspective. Then we have other calculators like REACH-B, PAGE-B, and HCC risk that take into account what's the cause of the cirrhosis, gender, presence or absence of cirrhosis, et cetera. I tend to use GALAD or maybe one of these other scores if I'm looking at a patient trying to decide about a surveillance strategy. So let's move into the future now, if that's okay. We have this long list of serum biomarkers. We have growth factors that may be associated with HCC diagnosis or more likely risk, RNA assays, microRNA assays, and also I'll talk about DNA tests here. So we have cell-free DNA, talk about integrity and quantification. We have somatic mutations that we can measure. We have circulating tumor DNA methylation criteria. We have 2 companies in this space, Helio and Exact Sciences. I'll talk about their data in a few moments. Circulating tumor cells, it's a little bit more difficult to access these cells from a blood assay, but definitely there. And then also RNA assays that are being used. I'm going to mention here just the second line down, which is Doylestown Plus. This used the GALAD score plus what was the fucosylated kininogen, showing very, very good AUCs. Look like this is better even than the GALAD score. So there are ways that we can modify the GALAD score. I have been advising Helio and Exact Sciences on how to design their studies. How are they going to get into the guidelines? How are they going to be accepted? And they really need to be an improvement on, or in some way, a competitor to the GALAD score, because I think that's really our foundation for comparison right now. So it's going to be very important as people move biomarkers forward that they really need to provide some type of cost savings, cost efficacy, or enhancement of our early detection. So this methylated DNA assay was looked at in the viral HCC world. You can see here an AUC that was 0.87, improvement over AFP with a threshold of 20, 0.56, or if you have an AFP cutoff of 12, about 0.62. Most of us really now use an AFP cutoff of 6. This comes out of a variety of different studies, including Brian McMahon's data from Alaska. Got some very good AUC data about using a combination of these different methylation markers. You can look at the left upper box and just look at the comparison of a single or 4 different markers for this. Really important though, in these studies, when people are describing these, they're really talking about measuring something now when they know the patient has HCC. The real dynamic is measuring something now in somebody without HCC, at least by ultrasound, and then early detection by some type of contrast enhanced study. So we have to take that into account. Exact Sciences came up with this nice study. It was, again, controls versus HCC cases. So we aren't diagnosing liver cancer by these biomarkers, although someday that may happen. I think it's going to be very difficult to replace imaging, because imaging just doesn't tell if you have cancer or not. It tells you how many, what does the cancer look like in terms of maybe even crudely the cellular behavior of that cancer. You have metastatic disease, you have vascular involvement, but early detection really comes back to key. So they can come up with cross-sectional studies, but it's really these prospective studies that are going to be key in terms of changing our behavior. This is the Exact Sciences data, including comparison to the GALAD score for early and late stage disease, showing reasonably important information, reasonably important sensitivity and specificity, but this prospective data that's going to be the most important. A little bit more from Exact Sciences, all stage, early stage, viral etiology, gender issues, outperforming by some numerical level. And of course, we have to decide if this is clinically significant. Gives you a little bit more data here about gender, cirrhosis status, child's PU A and B. And of course, these markers do need to show the sensitivity across a variety of different clinical settings. So Helio is another company that's in this space. The Exact Sciences, in terms of methylation markers, a relatively small number. It's under 10. The Helio approach was looking at 77 different methylation markers and coming up with artificial intelligence, this risk status. And they had a lot of other data that went into theirs. And they did wisely a comparison with GALAD and potentially use plus GALAD score. This is the Encore study, and I'm just going to do this build quickly because I just have a few minutes left. But 30% of patients were detected at this early stage across a variety of gender, forms of liver disease. And it looked like it had an improvement over the GALAD score. And here's performance data. Comparing the AFPL3, GALAD, ultrasound plus AFP. Sensitivity, not great, but the good news from this study to me was a low rate of false positive testing, because what happens with false positive testing is where we have harm that takes place. People always talk about harm in the screening environment, and low harm, low false positive rate is another compelling message in terms of how we're going to embrace this in our practice. This is Helio showing better results than GALAD, better than AFP alone, using these these AUC curves, sensitivity versus specificity. A little bit more here. This now across all the different levels of biomarkers using single or multiple GALAD or the Helio test, outperforming. But again, the cross-sectional analysis. Oops, sorry. One thing I just want to put on the table is that there is a study called the CLIMB study that Helio has funded, a prospective study that hopefully will then be able to embrace this, whether it's the same, better as, or a complement to our current GALAD scores. That's really, I think, the platinum standard, but we have gold and silver information, I think, that we can do today. This is a modeling study that Chatwal put out very recently. Also, a lot of details on this, but I'm just going to jump to the method. That in these modeling studies with the methylation markers, it led to definitely an enhanced rate of early detection. Modeling's good, but of course, we need real world data. I'm not going to go over this slide in great detail. It just summarizes in the top 4 boxes the different types of early detection markers that we could look at. I'm going to mention extracellular vesicles in just a moment. This will be combined with artificial intelligence, what's now called radiomics, including deep learning and other types of enhanced imaging. So I just wanted to bring that up. This is a glimpse novel liquid biopsy technology using a fluorogenic biosensor and machine learning, measuring protease activity in plasma samples. I think this is also encouraging, but I want to make sure if any companies in the diagnostic space are here, you really have a gold and now a platinum standard you have to look at in terms of prospective early studies and looking at the early detection network. It's very important. This is an extracellular vesicles. These EVs carry different types of messages. These also can be used for early detection. And this is called the ECG score using extracellular vesicles as well, combining with ultrasound, which I think will still be the standard for multiple years to come. MR, even short duration MR scans are still more costly. There isn't a billing code for these yet. And operationally, the MR scans are always busy, it looks like, at least in the region where I work. So I don't think MR is going to come in as a frontline test, except in what I think are high-risk patients. Two more slides on just these subpopulations that were looked at in UCLA. And looking at this HCC extracellular vesicle scoring system, detecting early HCC, also very interesting information. Then looking at a validation cohort at Cedars-Sinai. So I think this is another path forward. So we have different type of biomarker assays. We have 3 on the table today that are available through all of our labs. We've got excellent cross-sectional data, meta-analyses that are there. We've got historical data looking across Philip Johnson's data set. We have data from Japan, and I'm saying today GALAD score should be combined with ultrasound, and it's ready for prime time in your practice. These new assays from Exact Sciences and from Helio are available now as LDTs. You can get them done. There's challenges with insurance payment for those. The clarity on how those are going to do better than the GALAD score, in my opinion, is not yet decided, but I'm excited about the fact that there is so much investment going on in this space. Dr. Grady, Dr. Yang, other people giving these slides. I want to give accolades to Amit Singhal and all the work he's done with the early detection network. And I think I'm wrapping it up. Thank you very much for having me.
All right, we have a few minutes for questions and answers. I would love it if you do have a question, feel free to ask. Please use the microphones. There are microphones on the sides, and you can ask Doctors Wong or Gish anything about what they presented. Okay, we have a question.
I have a question for Dr. Wong. There's a difference in you talked about screening and treating. We're not treating everyone. And there is a difference between EASL and ASLD guidelines. I can live with that. What my struggle is in both guidelines, they say to initiate treatment once you get F2 fibrosis. In America, 70% of our population is overweight. So there is the concurrence of fatty liver disease. I'm getting a fiber scan. Their numbers are not that high. Fiber scan says F2 or 3, and I struggle. Should I be treating this patient or not? Maybe it's time to revise the guidelines a little bit to give some guidance on that.
Hello. Yeah, I think that's a great comment. And I totally agree with you. There's definitely momentum across multiple societies, including in the US, on how we can not so much expand, but perhaps simplify treatment for chronic hepatitis B. There's more and more emerging data that those that are not meeting the traditional treatment eligibility criteria, these patients still have risk of disease progression, still have risk of HCC, still have liver-related comorbidities, poor patient outcomes. So I think you're right. The needle is shifting and the tide is moving. I think in the near future, I hope that there will be continued embracement of how we can evolve, expand, and perhaps simplify treatments and really treat hepatitis B like we would for any infectious disease. You have an infection, you have a virus. Granted, it's very different than Hep C, where we have 8-12 weeks of therapy that translates to cure. We don't have something that has high levels of functional cure at the moment. And so for the most part, it's viral suppression, but still the concept is the same. It's an infectious disease. Not only are you treating the patient, but also the concept of treatment as prevention. Treating the patient, potentially preventing transmission of disease as well. So I think definitely there is movement, there is discussion, and I hope very soon that we'll be able to move the bar on treatment. I think Dr. Gish also has comments on this.
I'm going to take a much stronger position than Dr. Wong, who's being politically adept, but I think it is time to make this very simple. So I've been crowdsourcing something that I call the 5-line guideline. You have 5 lines. That's all you need to know about hepatitis B. Number 1, test everybody with a triple panel negative, vaccinate. That's obviously already set up in CDC, ACIP. Surface antigen positive, you check DNA, you check Delta antibody. Super simple, inexpensive. DNA positive, you treat. And of course, number 5 is you have to stage your patient and decide on when to start surveillance. The Chinese guidelines came out, said over 30, over 2,000, treat everybody. That is the standard of care for the entire country of China as of 2 weeks ago. Also, the SABA guidelines from Doug Dietrich came out almost saying the same thing as the Chinese guidelines, a couple of nuances. So we're moving that direction. We had last fall 2 3-hour meetings with Hepatitis B Foundation with KOLs from all over the world. 38 out of 40 said, make it extremely simple. In fact, a couple of people want to just treat everybody who's surface antigen positive. So you've got your Hep B patient, viral load's 900, they got fatty liver, they're drinking 2 servings of alcohol a day. This is a very typical scenario. Just the fatty liver on top of hepatitis B can increase cancer risk up to 20 times. That's Rohit Lumba's paper, Gastroenterology in 2011. So fatty liver plus B, you're going to treat at any viral load. Cirrhosis, any viral load, you treat everybody. Everybody's infectious, treat everybody. It's a stigmatizing disease. It decreases quality of life. So Barry Yanusi is one of our leads at this meeting. Decreased quality of life. You would treat people, they feel better. And when they're on treatment, most, not every patient, is destigmatized. They're on treatment, they're less infectious, they feel better. They're doing something about their disease. So I think the guidelines are very binary. You're alive, you're dead. You have cirrhosis or not. You have cancer or not. They don't take into account all these other factors that Dr. Wong just went through that should be part of why we treat everybody. Make it simple. HIV, we treat everybody. Hepatitis C, we treat everybody. Hepatitis B, we have 36-page guidelines, 400 reference articles, and confusion.
Thank you. Any other questions? Okay, I think we are finished with the question and answer session. Okay, we're going to move forward now. And we're going to have 2 talks in a row which talk about treatment options for hepatocellular carcinoma. First, Dr. Mehta is going to talk about surgical treatment options. And then to follow, Dr. Finn is going to talk about systemic and radiologic treatment options. Dr. Mehta.
All right, thank you very much. Really appreciate the opportunity to speak today to the organizers. So I'm going to be talking about surgical treatment options for HCC, and then we're just going to come up and talk about local regional therapy and systemic therapy options. So first, we'll talk a little bit about diagnosis and staging, including LIRADS and BCLC criteria. And then we'll also talk about both resection and liver transplantation in terms of criteria, how do the 2 modalities compare to each other, as well as salvage transplantation. So we'll do this a little bit case-based, loosely, I guess. So this is a 55-year-old gentleman with alcohol-associated cirrhosis who's found on screening ultrasound to have a 3-centimeter lesion in the right lobe. You do a quad phase CT and it confirms a 3.5-centimeter lesion in the right lobe along with mild ascites. The patient has no spiders. The spleen tip is palpable with a platelet count of 85,000. You can see the bilirubin is slightly elevated at 1.7. Same with INR 1.3. And his AFP is also mildly elevated at 36. And so when we have to ask ourselves, and when we're in tumor board, is, what are the typical characteristics of HCC on a quad phase CT, and should we biopsy this lesion? And so this we talk about a lot in tumor board as well as conferences. Do we biopsy? Don't we? And depending on whether it's an oncologist or hepatologist, or everyone has a different opinion. But in general, biopsy is not necessary to confirm an HCC diagnosis if the lesion meets the radiologic criteria in the appropriate clinical setting. So someone who's at risk for HCC who then has a LIRADS-5 lesion. While false negative biopsy can occur, it definitely can lead to delays in diagnosis and treatment. But in general, one of the other concerns was tumor seeding, and that is extremely rare these days. So we don't really worry too much about needle track seeding anymore with coaxial needles, but we do worry about false negative biopsies leading to delays. So in general, we tend to biopsy LIRADS-M or M for malignant lesions, or if someone doesn't have a strong risk factor for HCC. So the LIRAD system has been around for over 10 years now, and we're going to go through these both today as well in my talk, as well as some of the cases. But these are the main kind of features that we're looking for on our quad phase CT or MRI. We're looking for arterial phase hyperenhancement and delayed phase washout. HCCs are predominantly fed by the hepatic artery, whereas most of the liver's blood supply is from the portal vein. And so you get this arterial phase hyperenhancement with delayed phase washout. You can also get a capsule, and these lesions can also grow. So these are the main criteria. And it's important to know that the larger the lesion, the more likely it is to be HCC. And so this is a classic example. I think I saw a pointer earlier. Perfect. So, you can see we're in the arterial phase, aorta is bright. You can see an arterial phase hyperenhancing lesion. And then when the rest of the liver is getting its portal venous blood supply, now the HCC looks stark and is washed out. Lesions can also have a pseudocapsule. And then so we have this nice, criteria here from 1 to 5. And it's important to know that each of these kind of represents a different likelihood of turning into HCC. So our LIRADS-3 intermediate lesions or indeterminates are about 35 to 40% typically HCC. LIRADS-4 lesions are more like 65 to 75%. So we call them probable. And then LIRADS-5, even though it's called definite, only 95% are actually HCC. And so more and more people are getting excited about biopsying kind of all lesions because, 95% is not definite, but I guess for us, it's good enough. And then LIRADS-M lesions are mostly malignant, 95% of the time, and a minority of those are HCC. And so this is kind of a somewhat complicated slide in terms of kind of going through arterial phase enhancement, size, as well as the other diagnostic criteria, washout, capsule, threshold growth. Thankfully, our radiologists typically do this for us. But the reason I point this out is oopsie, we went a little crazy there. So the reason I point this out is because, we're right here in the bottom right is when we're worried about our LIRADS-5 lesions, but there's been a bit of complexity in this kind of one diagnostic criteria with arterial phase enhancement in the 1 to 1.9 centimeter range. It sounds like a very, very specific thing, but we're trying to align ASLD, LIRADS, and OPTN classifications. And so these lesions, if they do have a washout or threshold growth, they are actually LIRADS-5. And the reason why that's important in my field is because if they have 2 such lesions, they can actually get MELD exception for liver transplantation. So when we're thinking about how to go about treatment options for this patient I presented earlier, we tend to turn to a lot of different staging classifications. This is one that's just updated. This is a BCLC staging classification that we'll kind of go through. But when we're thinking about this patient, we have a lot of different treatment options that we should be considering. So this is the same patient I mentioned earlier, but now we've done a tumor board review and it's a LIRADS-5 lesion. And so we really have to ask ourselves, okay, should we try to resect this lesion? And if so, should this be anatomic or non-anatomic resection? Should we think about transplant, or we should think about ablation of this 3.5 centimeter lesion? So when I think about these different options, for me, portal hypertension comes to the forefront. And so this patient clearly has splenomegaly and a decreased platelet count under 100,000. And so resection does not seem as appealing anymore. And ablation, is we'll talk about, but is not ideal for lesions 3.5 centimeters, especially on its own. It may be combined with something like TACE or Y90 or SBRT, but on its own, it's probably not a great single option for a 3.5 centimeter tumor. And so when we're thinking about these decisions, the BCLC nicely takes into account tumor burden, liver function, physical status, and it's been refined But when we're on the left here, we're talking about kind of early stage single lesion. So resection and transplant would be our two kind of decision tree here. Also, it's important to know that in the intermediate stage, which we'll talk about a little bit later, transplant is an option here as well. And now BCLC has incorporated downstaging into this classification system. So, resection is still the gold standard. It's still the ideal. If we can get patients, if patients are resectable, that should be what we pursue. The problem is that almost always, patients, especially in the West, are not resection candidates. So, in Asia, where there's a lot of Hep B, HCC, those patients often are non-cirrhotic and they can be resected. If a patient's decompensated, then resection is not a good option. But the Child's A compensated patient, that's where we have to think a little bit more nuanced about what are our options. So one of the things we talk to our fellows about all the time is, okay, what's their platelet count? What's their bilirubin? If someone has no portal hypertension and normal bilirubin, they often can do really well with resection. But on the other hand, if they have both, if they have portal hypertension and an increased bilirubin, they actually have quite poor outcomes with resection. And so when I think of the ideal candidate for resection, I think of someone with Child's A, good preserved liver function, no clinically significant portal hypertension. I want them to have a normal bilirubin. Ideally, size does matter. Ideally, they're on the under 5 centimeters. I'll show you some data on that in a moment. And then more and more we're seeing minor hepatectomies and laparoscopic approaches. And so if a lesion's kind of segment 6-7, if it can be done laparoscopically, especially left lateral, segment 2-3 would be a really good option for a laparoscopic approach for resection, which should decrease your morbidity and mortality. This is an algorithm that we're going to be including in our upcoming ASLD clinical practice guidance that should be coming out this month or next month. So this is how we are thinking about surgical treatment of early stage HCC. So you can see here that, if someone has multiple lesions, we often wouldn't think about resection just because their rates of recurrence would be quite high. But if someone has a single lesion and they're compensated with no clinically significant portal hypertension, there's a lot of ifs. But if they hit all those buttons, then resection would be a viable option. The problem, of course, with resection is that recurrence is extremely common, probably up to 70% out to 5 years. And so there's a lot of known risk factors for tumor recurrence. These are including vascular invasion, multifocal disease, larger tumor size, positive resection margins, lymph node involvement, and high AFP. There was a press release that for some of these higher risk patients who undergo resection, that combination of atezolizumab and bevacizumab for a year may improve recurrence-free outcomes. And so hopefully we are eagerly awaiting that data in the next few weeks. And then the other thing that can really predict resection outcomes is kind of what does the underlying liver look like. So this is a nice study in JAMA Surgery from a few years ago that showed that if a patient has cirrhosis and they undergo resection, their risk of recurrence approaches 75%, as opposed to if they have a normal, meaning like no fibrosis at all, they have a much lower risk of recurrence, really highlighting the importance of that underlying liver in being a kind of a harbinger for tumor. What about transplant? So transplant, as this group probably knows, is the best oncologic resection. It replaces the diseased liver and restores normal hepatic function. There's been multiple retrospective kind of studies or meta-analysis that have compared recurrence between the two, and there's no doubt that transplant does much better, obviously. There has never been a single head-to-head prospective trial comparing resection to transplant. And so that kind of makes that part of the talk easy because I don't have great data to show you. But, in the US, we still use the Milan criteria. So this is single lesion up to 5 centimeters or 2 to 3 lesions, none greater than 3 centimeters. And then patients cannot have macroscopic kind of vascular invasion or extrahepatic spread. So that's the Milan criteria. But within the US, we no longer give points for patients with a single small up to 2 centimeter or 1.9 centimeter tumor. So we only transplant patients who initially had T2 criteria or are downstaged into Milan criteria. But with these criteria, patients do extremely well with 5-year survival, over 80% and relatively low recurrence rates. When we think about recurrence, HCC recurrence is the most common cause of death after transplant. And so we really have to strive to have good patient selection to prevent recurrence or at least minimize it. In large part because once you recur after transplant, your median survival on average is only 1 year. So the field has changed a little bit over the last 10 years in terms of policy changes. So we have incorporated LIRADs, which has been a nice unifying effort. So as we mentioned earlier, only patients with NT2 or Milan criteria with LIRADs 5 lesions can have priority listing for transplant. We've also instituted in 2015 a 6-month mandatory wait period before awarding MELD exception. That's basically data from Julie Heimbach and others that showed that HCC patients used to be highly advantaged in the old system. And so now that we have this built-in delay, we have much better equalized access for HCC and non-HCC patients to transplant. We also used to have a good amount of regional variation in access to transplant for HCC. This is not just for HCC, but in general is a very hot topic with a lot of articles coming out in the Post and the New York Times recently about kind of access and rules. But you know, the data at least was fairly strong back then that HCC patients, depending on where they lived, had extremely different risks of waitlist dropout. And so we said, okay, if we're just going to arbitrarily assign MELD exception, we might as well give it so that patients have pretty much normal access or equal access so that patients aren't flying from one state to another with HCC. And so we basically got rid of the ladder system for awarding MELD exception. And now we give, after a 6-month wait, we give median MELD to transplant -3 around the donor hospital. One of the other things that mattered, you know, so Dr. Gish already started to go through some of these, this data about how biomarkers can be quite useful in prognostication. And so this is a French multi-center study that was very nicely showing how important AFP was for post-transplant outcome. So you can see here that patients with an AFP over 1,000 do extremely poorly with transplants. This is UNOS data that shows kind of very similar data and actually starts to show that even with an AFP as low as 16 to 65, your outcomes with transplant start to worsen. And so we may not think too much about an AFP of 36, but it actually is going to increase your risk of recurrence. And this is a nice kind of summation of tumor burden with AFP in the Metro Ticket 2.0 calculator that Matzafera and colleagues came up with. And so on the x-axis, you can see a version of tumor burden. And on the y-axis, you see AFP. And you can say, okay, this is the Metro Ticket. The further we go on the train, the more we push the envelope, the higher risk of recurrence we're going to have. The good thing about the biomarkers is that they're just like with disease response to local regional therapies, if you can have AFP biochemical response, then you can actually do quite well with transplant as well. So this is a group of patients that if they actually can get their AFP down from over 1,000 and then get treated and it comes down to under 100, they have 88% 5-year survival. So it's not really where you start with some of these biomarkers, it's kind of where you finish. So this is now national policy that candidates with a lesion that meets T2 standardized criteria, but with an AFP over 1,000 have to come down to under 500 before they can be get MELD exception. But ideally, they would get down into the single or double digits. Now we started to hear about some of these other biomarkers, including L3 and DCP from Dr. Gish. So this is a retrospective study from the Mayo Clinic that showed that DCP and AFP L3 may be more important than AFP in predicting post-transplant recurrence. And then this is our own data from UCSF that a single center, relatively small study, but does show quite clearly that if you are above both an L3 and a DCP cutoff here, that dual positivity predicts extremely poor outcomes. And so this is something that we've now incorporated at UCSF, and now we don't transplant these patients. If they meet dual positivity, we'll put them on hold and try to do more local regional therapy to try to get at least one, if not both of those biomarkers down to normal range, and then we'll reactivate them for transplant. Okay, so so that was kind of a single 3.5 centimeter tumor that we were debating resection versus transplant. In this case, we have a 56-year-old male with chronic Hep B. We kind of already heard a little bit about inadequate HCC surveillance. And unfortunately, in this case, the same thing happened. So this patient presents with 2 sizable tumors, 5 centimeters and 3 centimeters, platelet count 84,000. So again, we're not really thinking about resection in someone with 2 relatively sizable tumors. And so really what and this is not the exact patient, but a similar patient. And so you can see that kind of the 2 tumors in the right lobe. And so now we start to think about, okay, what treatments do we have for this patient? And again, similar options, resection, microwave ablation. If they saw an oncologist first, they may be considered for atezo-bev or liver transplantation after downstaging. And in my mind, the best chance this person has of kind of a cure would be downstaging with transplant. And so what is downstaging? It's basically a reduction in the size of tumor using local regional treatments to meet acceptable criteria for transplant. And we like it because it's a selection tool for tumors that are kind of have more favorable biology that because they're responding to downstaging treatments, we think they'll probably do better with transplant. So this is a different patient. It's nice to kind of show that when they initially present with them beyond Milan, you can be downstage but still have viable tumor, and that's what we're showing in the middle panel. And then after another treatment, now that looks completely dead, ideally they'd have complete tumor necrosis. And so we do attempt to keep doing treatments as long as the patient's tolerating these treatments with a goal of trying to get totally non-viable tumor. So I'm not going to go through the laundry list of ways we can downstage patients, in large part because we have a nice local regional therapy talk from Dr. Finn coming up, but we have a lot of options. So a lot of this is center specific, but Y90 is largely in many centers replacing TACE as the most common arterial therapy. But we have a lot of different ways to downstage patients, but in general, we have national downstaging criteria that we now follow. And so our patient who has 2 lesions, large as 5, total tumor diameter up to 8 would actually qualify for the standardized national downstaging protocol, such that if they got local regional therapy and came down within Milan, now they can actually qualify for automatic MELD exception. This is in large part based on data showing really nice outcomes after transplant in this select group of patients. And so this is 3 centers from region 5 showing 80% 5-year survival with relatively long post-transplant follow-up and low rates of recurrence. We also have a multi-center downstaging randomized controlled trial out of Italy that was quite interesting. Small study, but basically they downstage patients and then randomized them to either transplant or no transplant, which you can wonder if it's ethical, but it was done, and not surprisingly, it showed that the transplant arm did much better. And so, we have nice proof of concept here that downstaging works. So like I said, this patient would meet downstage protocol, and so we want to know what are their kind of what are the expected outcomes here. And so this is a multi-center consortium we have with several of the centers here in the audience. We call it Merits LT, and so far, the original publication from 2 years ago now had 209 patients. With a very high probability of successful initial downstaging if they met these downsstaging criteria, approaching 90%. We looked at first type of treatment. People always say, okay, well, should we do TACE or Y90 or what's? It turns out it's both seem to give high rates of downstaging. One note of caution, though, is these patients, when they got to transplant, tended to have quite a bit of tumor that was, we think patients are within Milan, but actually almost half of them actually were beyond Milan. And so that's something that we need to work on and probably continue to do local regional treatments to try to reduce tumor burden going into transplant. What about in the UNOS database? About 11% of patients meet the UNOS downstaging criteria, and a smaller subset, about 3%, meet the all-comers criteria. These are patients beyond UNOS downstaging with quite high tumor burdens. Those patients still do relatively well with transplant, 71% 3-year survival, but just not as good as the Milan or the UNOS downstaging arms. And then one of the last studies I'll show you is this, one of my favorite studies that really nicely compared transplant and hepatic resection. And the title of this was Both Can Achieve Cure for HCC, which is not surprising, but I liked what they did here. And so this is a huge numbers, 1,200 transplants, 2,000 resections. Not surprisingly, more people in the transplant arm were within Milan, and more people in the hepatic resection arm had lower MELD scores and had larger single tumors. And it may be hard to see, I apologize for that, but basically you've probably seen transplant curves before in terms of overall survival, so that's not too surprising. What is interesting to see is that at 5 years and beyond, at 10 years, you can see that overall survival was about 30% in the resection arm. And so, and sorry, this got a little messed up, but basically what we're showing here is that it takes almost 11 years to actually say someone with resection has been cured, which is obviously a long time. And so we do need to be following these patients with cross-sectional imaging, especially if they have cirrhosis. They are at extremely high risk for recurrence after resection. Whereas with transplant, we typically say a patient can be cured after 5 years. And then one of the other reasons I like this study so much is because they nicely broke this up by tumor burden. And what you can see here is that if someone has a lot of tumor, if they're over 8 centimeters, or if they have multiple tumors, especially more than 3, resection is probably not a good strategy here. But who are the good patients to consider resection? Well, especially you have to think about the risk of waitlist dropout, right? We don't have just a ton of liver organs available. And so patients are on a list and they have a risk of waitlist dropout. And so that has to be taken accounted for. And so patients with single tumor up to 3 or 3 to 5 actually do relatively well compared to transplantation. So again, a little bit of thinking about how we should be, who are the patients with HCC who we should be considering for transplant versus resection. And then finally, in terms of salvage liver transplantation, so multiple studies have assessed the strategy of basically you resect someone, and if they recur, then you'll pursue salvage transplantation. And so this is a study, there's been multiple studies, this was published in Hepatology a few years ago, that showed that salvage transplantation, either they never recur or you then transplant them, they do quite well, versus if you resect them and they either have kind of go into liver failure or recur without transplant, they do quite poorly. And so that's one of the important predictors of the strategy was if they initially were T1 or T2. And then there is some data that salvage transplantation, those patients do just as well as primary liver transplantation. And so we've also incorporated this both into UNOS policy as well as this practice guidelines I showed that now once patients are resected, if they recur within Milan, they're eligible for MELD exception without a 6-month delay. And so that's a nice option for those patients. So to summarize, resection requires an assessment of tumor burden, portal hypertension, MELD score, and extent to resection. Resection is associated with higher recurrence than transplant, but still should be considered first-line treatment, especially with single small tumors and in the setting of organ shortages. This should be, transplant instead of resection, but the Milan criteria remain the gold standard in the US, though biomarkers should be incorporated for selection, for example, AFP, or maybe even in the future L3 and DCP. After a 6-month delay, patients are now eligible for immunomelda transplant -3 rather than the previous ladder upgrade, and that's true for both Milan and UNOS downstaging patients. That's been incorporated as national policy. So thank you very much. I have the pleasure to introduce now. All right, Dr. Fenn's up next. Yeah, no, it's good.
You have a great voice for doing announcing, so appreciate it. But thank you very much to the organizers to have me here. I'm a medical oncologist, but I work very closely with hepatologists and surgeons, and it's always a real privilege to talk to my colleagues in hepatology, such as this meeting. So to jump right in, and you've heard about staging earlier, the BCLC recently updated its staging paradigm and really did not make significant changes. But when we look at this, they've highlighted some things we've known for a long time, and that is the heterogeneity of Barcelona stage B. These are patients who have liver-confined disease that historically have gotten local regional treatment. However, we know that probably not every patient that technically is Barcelona B does well with local regional treatment. And they identified this group of patients who are diffuse tumors or large tumor burden, bilobar, who they've now suggested go on to receive systemic treatment up front. At the same time, they've recognized that some patients who get intermediate disease will be downstage to transplant, and you heard some of that in the prior talk. And so when we talk about patients who are candidates for medical treatment now, we're talking about those patients who have clearly advanced disease, and this is patients who have extrahepatic spread or metastatic disease, as well as those who have vascular invasion. And again, that's an area of some debate with the interventional radiologists, but we know that patients who have vascular invasion do not have as good of outcomes with local regional treatment, and we do know clearly there's a survival advantage for those patients with medical treatment. And we talked about this group of patients with diffuse disease, and keep in mind patients who get local regional treatment, such as TACE or Y90, assuming they don't die from some other cause or from cirrhosis, they eventually will progress. They can have repeat local regional treatments, but eventually they will develop some criteria, i.e. vascular invasion. They'll be refractory to TACE, meaning you do a procedure. By the time they're reimaged, they'll have new tumor or residual tumor. And those patients might still be intermediate, but will require systemic treatment. And we'll talk about the systemic options. So there's been a number of positive phase 3 studies in the past few years in the front line as well as the second line setting. I just highlight some of the take-home messages from these studies here. For one, in 2008, the SHARP study was placebo-controlled and established sorafenib as the standard of care for patients with advanced disease, a very significant benefit when we look at overall survival, a 31% decrease in the risk of death. However, it did this without inducing objective responses. It did this by slowing progression. And I think a lot of people did not gravitate to this because of the lack of response, even though it improved survival. Now, you can see from 2008 to 2017, we did not have a new drug in advanced disease. We had numerous negative studies that could not beat sorafenib. For all its weaknesses, it maintained the standard of care. Now, in 2017, sorafenib was compared to lenvatinib, another oral tyrosine kinase inhibitor. This study did not show that lenvatinib was superior, right? It was non-inferior. The hazard ratio here of 0.92 did not reach superiority criteria. However, it got approval because it was another option for patients and it has a little different side effect profile. Importantly, it did delay progression-free survival and is the one tyrosine kinase inhibitor that has a modest objective response rate with 19%. The big change came, and with all my conflicts, came with the approval of atezo-bev in 2020. This was the first time that a regimen compared to active treatment, sorafenib, improved survival significantly. Hazard ratio 0.58 for OS as compared to 0.69 versus placebo, as well as an improvement in progression-free survival and an impressive objective response rate of 30%. And if you respond, those are very durable responses. And then this past year, or I guess last year, we saw the approval of another immunotherapy regimen, durvalumab and tremelimumab. Again, a hazard ratio of 0.78 that was significant versus sorafenib. There was no real benefit in progression-free survival, modest objective response rate of 20%. Now, it's important that not all these studies have looked at the same population. While they've all focused on advanced liver cancer, and generally those are Barcelona stage C, all of them have included patients with intermediate disease, and those would be patients who weren't candidates for TACE or who had progressed on TACE. But a very important prognostic factor is main portal vein invasion, or VP4. And you can see that only 2 studies did include those, the sorafenib study and EMBRAVE. And it's important to keep that in mind when we approach and look at these data sets. So the pivotal study with sorafenib, you've seen many times. I commented that this was the standard of care for more than a decade. Here you see the results from the REFLECT study that looked at lenvatinib versus sorafenib. 13.6 months, I want you to remember that number, versus 12.3. The hazard ratio was 0.92. The upper limit of the confidence interval was 1.06, which means it wasn't superior. But since it was less than 1.08, that met the non-inferiority threshold. Now, immunotherapy has revolutionized cancer medicine. The Nobel Prize was given to James Allison and his colleagues in Japan, I think 2 years ago now, for their identification of the importance of immune checkpoints in treating cancer. And what we know about immune checkpoints is that the immune system is very highly regulated in the normal state. One of the ways that cancer evades the immune system is by expressing proteins that downregulate the immune system. One of them being the interaction between T cells and antigen-presenting cells. And there's antibodies that target CTLA4, which then primes the immune system. Or on the tumor engagement side, tumors can express programmed death ligand 1, which binds, or programmed death receptor 1, which binds to PD-L1. Take that back. PD-1 receptor is on the T cell, right? And PD-L1 ligand can be expressed by the tumor and essentially tells the tumor, don't eat me, don't engage, a cloaking signal. And numerous antibodies have been developed that interact and interrupt the signal between the T cell and tumor and have really revolutionized medicine because diseases like melanoma, lung cancer, where patients had very poor prognoses, are now doing very well. And I will argue that liver cancer now has one of the best outcomes for advanced disease for a solid tumor. There was a lot of excitement for nivolumab, the first PD-1 inhibitor to be looked at in liver cancer in a critical way. That early study was led by my friend and colleague across town, Anthony El-Khoury. And nivolumab got accelerated approval in the US, but the confirmatory phase 3 study here was negative. The survival with Nivo was 16.4 months versus just under 15 months with sorafenib. So keep in mind, survival with sorafenib has gotten better over time, and that's a whole nother discussion. This study, nivolumab had an objective response rate of 15%, exactly seen in the accelerated approval label. However, with a hazard ratio of 0.85, the confidence interval crossed 1 with a high p-value, and therefore this was not significant. Keep in mind, if this was called a non-inferiority study, like lenvatinib, it would have been positive because the upper limit here is 1.02. But when you start the game, you determine what kind of study you are, and therefore you're held to that. Now, recently at the ESMO European Oncology meeting, we saw the results of another PD-1 inhibitor, tislelizumab, and very similar results, 15.9 months, 16 months versus 14 months with sorafenib, hazard ratio of 0.85, exactly the same. Here you see the upper limit of the confidence interval, 1.019, so 1.02. This study, though, is positive because it was powered for non-inferiority. But needless to say, single-agent PD-1 inhibitors do have activity in liver cancer. And here you see the objective response with this drug was 15%, 14%. And what's striking about immuno-oncology agents is if you respond, those are very durable, right? You can see the median duration of response was 3 years with this drug. That's remarkable. The problem is we don't know who responds. We don't have a biomarker. We don't have a clinical marker. So therefore, there's been interest in combining IO agents. And there's been several of those studies done, and I highlight them here. Atezo-bev, positive. There was this study from China that looked at another PD-1 inhibitor and a drug similar to bevacizumab, positive. There's been combinations of kinase inhibitors and IO, immunotherapy agents. These have largely been negative, except for this one that came from China, again, presented at ESMO. And then IO, using CTLA-4 and PD-1 inhibition. This study, Himalaya, was positive. We talked about it, and Nivo-Ipi is ongoing. So IMbrave looked at patients who were advanced and open label atezo-bev given IV every 3 weeks versus sorafenib. This study met its primary endpoint of improving OS with a very significant hazard ratio. And we see here the survival with atezo-bev is over 19 months. And that is now the benchmark for drugs moving forward. And with this data, we see the objective response rate is 30%. And again, if you respond, a very long duration of response, 18.5 months. Now, I want to highlight here an unmet need in liver cancer. So this is a frontline study, and you can see if you have an objective response, your survival is very good. We still had not reached the median in OS for responders. If your best response is stable disease, still your survival pretty good. But if you don't respond to atezo-bev up front, that's a very poor prognosis. Your survival is about 7 months, and we need to figure out what's the next best thing for these patients. The other thing I commented on was this vascular invasion issue, VP4. Now, this study included VP4, and if we look at just the high-risk patients who are VP4 and some other characteristics, again, a high unmet need. Their median survival is only 7.5 months. Better than sorafenib, but still an unmet need. And without those patients, we see a survival of 23 months in the overall population. This regimen is very well tolerated. The most common side effects with atezo-bev are typically from the bevacizumab, the VEGF component, hypertension, proteinuria. Things, all grade toxicities are lighter, high grade are darker. And as you know, GI toxicity and hand-foot skin syndrome are a bigger problem with sorafenib, and therefore the quality of life is improved actually with atezo-bev. Now, bevacizumab affects vessels. Patients with liver cancer at risk for variceal bleeding. All patients in this study needed an upper endoscopy within 6 months of coming on study, and by and large, that is how we should use this regimen in practice. However, most of the bleeding events tend to be low grade, epistaxis, hematuria, gingival bleeding. However, there are high grade events, but overall not that too dissimilar than sorafenib, which is also a VEGF inhibitor. If we look at serious events, and here we're looking including grade 5, there were 4 death events from GI bleeding in atezo-bev and none with sorafenib, even with upper endoscopies and these patients being Child-Pugh A. But we know that these patients were the ones that also had main portal vein invasion. So clearly that is a risk factor for high risk bleeding. So we talked about lenvatinib, a multikinase inhibitor that's very active in liver cancer. Also, pembrolizumab, another PD-1 inhibitor, is currently approved by the US FDA in second line. And really, it's based on the fact that in patients who had prior sorafenib, the objective response rate is 18%, and these are very durable responses. We looked at the combination of lenvatinib and pembrolizumab in combination and showed a very high response rate. Here we see a response rate of 36% in this single-arm study. We went on and did a randomized study of lenvatinib and pembro versus len and placebo. This was the first placebo-controlled study in liver cancer really since sorafenib, because most studies have been IO, IV versus PO. But here we had IV in both arms, so it was blinded. And this is an interesting comment on the modern age of liver cancer. You can see here that len pembro had a survival of 21 months. Quite good. And in this study, we excluded main portal vein invasion. So again, 21 months is an impressive number considering where we were not that long ago. However, lenvatinib alone, a TKI alone, gave a survival of 19 months. I just showed you in the REFLECT study, the survival was 13.5 months. So in 5-6 years, the survival in the control arm for advanced liver cancer has markedly improved. And there's several reasons for that maybe we'll talk about in the discussion. Still, this regimen gave an objective response rate of 26%. Lenvatinib alone confirmed, again, a response rate of about 17.5%, very similar to the REFLECT study. However, that study, despite looking very promising with len pembro, did not reach statistical significance and will not be FDA approved as is. Now, nivolumab and ipilimumab, a PD-1 inhibitor and CTLA-4 inhibitor, have been looked at in combination here in a phase 1-2 study, looking at 3 different dosing regimens of ipi-nivo. All of them showed a response rate of 30% post-sorafenib with a long duration of response. Arm A, this dosing regimen actually had a survival of about 23 months in second line. And based on this data, this regimen got accelerated approval from the FDA and is currently in a study in frontline, and we're waiting for those results. Something I want to comment on is when we combine IO agents, we see a significant increase in immune-related adverse events. That was always the issue and concern with immunotherapy in liver cancer patients. These drugs work by activating the immune system, and essentially all the toxicity is related to that mechanism. Most commonly, we see rash, hypo or hyperthyroidism, but in reality, we can see any kind of itis from the brain, diabetes, endocrine, adrenalitis, hypophysitis, you name it, including hepatitis. And therefore, there was always a concern in cirrhotic patients. But we know now that that risk is very low, and generally, these drugs are very safe. Himalaya looked at the combination of tremelimumab, a CTLA-4 antibody, with durvalumab. And interesting, in this regimen, patients get a single dose of tremelimumab at beginning. The study also had other arms looking at durvalumab alone, and then the control arm of sorafenib. But the primary endpoint was to look at the combo versus sorafenib. This study met its primary endpoint of improving overall survival. The hazard ratio here was 0.78. Median survival went from 14 months to 16 and a half months. And quite interestingly, there's a nice tail to this curve. If you look at 2-year and on survival, it tends to taper around 30%, suggesting that even a single dose of CTLA-4 antibody may affect long-term outcomes. This study did not include patients with VP4 invasion. Durvalumab alone actually had activity. Again, the control arm doesn't change, 13.8. Durvalumab itself, 16.6 months, which is not too different than the 16.4 months we saw with the combo. However, this arm did not reach a superiority endpoint. The upper limit was 1.03. It met a non-inferiority endpoint, but single agent IO does not have an approval in frontline. There was no change in PFS between the arms, but objective responses were higher with the combination, 20%, Durv alone 17%, sorafenib as expected, low single digit. And the duration of response, as we've seen with these drugs, is quite long when you see a response. These drugs are very safe, as mentioned before, as compared to sorafenib. If you look at grade 3-4 events, very similar. However, immune-related adverse events are what we see with this combination. And what's interesting is if you look at patients who need steroids to manage an adverse event, 20% with the combo versus 10% with single-agent durvalumab. There's a number of drugs approved in second line. All of these were approved after prior sorafenib. How we use them in the age of immunotherapy is up to expert opinion. Many of us will sequence these drugs with the assumption that they will still provide patients some benefit regardless of what they found and what they received in the frontline arena. And I have patients now who are receiving third, fourth, fifth line therapy with advanced liver cancer, which is remarkable. And we're sequencing patients through these drugs. And it's important that we find patients with well-compensated liver disease. I have patients who are actually outliving their liver disease. Their tumors are controlled, but they start to decompensate. And in order to get a long enough runway to offer them treatment, we need to find them early. I propose this paradigm because I think atezo-bev is the most active regimen we have based on objective response rate, survival benefit, tolerability, PFS improvement. The first thing we need to rule out is the use of bevacizumab and whether or not they have high-risk bleeding or at risk for ischemic events. If they don't, then do they have a contraindication to checkpoint inhibitors such as immunotherapy? And if they don't, then atezo-bev and then sequencing through other drugs. If they can't get bevacizumab and they don't have a contraindication to IO, then we have other IO regimens. Really, at this time, the only one that's approved is durva-tremi, and that would be an acceptable option. If patients can't get checkpoint inhibitors, then they're going through a sequence of TKIs. I think it's a small population of patients, really those who have significant autoimmune problems. There's a number of ongoing studies in earlier stage disease. On April 16th, the results of IMbrave 050 will be presented at the AACR meeting. Dr. Mehta commented on this. This is a study of atezo-bev after curative resection, the first positive adjuvant study ever in liver cancer. And also there's studies looking at moving these drugs into combination with local regional treatments. There's a lot of rationale to combine IO with these approaches. You do LRT, you induce antigen release, and potentially improve outcomes. So in respect to Dr. Kuluk, I want to comment briefly on radioembolization because I was tasked with this at the beginning. In the United States, radioembolization has had a very rapid uptake for intermediate disease. And I generally do not comment on what interventional radiologists want to do. I will comment that head-to-head studies have never shown that radioembolization is superior in survival for TACE. Globally, all the global local regional combination studies are looking at in combination with TACE, because globally radioembolization has not taken off, but it is a very effective way of treating tumors that are intermediate stage. There's been several studies that have looked at radioembolization in advanced disease versus sorafenib, and those have been negative. But I think for the true intermediate patient, that these are very appropriate modalities. And Northwestern, which has really driven this, Riyad Salem, who has really driven, I think, the development of Y90 for many, many years, and I applaud him for that. They have actually adopted Y90 as their standard for local regional treatment, and formally made a statement and presented these data where they show very nice outcomes. And again, if we concentrate on earlier stage disease, survival rates that are very favorable, even for larger tumors. And one of the things that is new in this space and has been put forward as an argument of why some of the phase 3 studies might have failed, or even the studies versus TACE, is that they've learned how to dose the Y90 better. And here, using personalized dosimetry versus just a fixed dose of radiation really is the key way to go to help improve outcomes. But globally, I think we're still waiting to see how this is adopted. So we've made a lot of progress in liver cancer. Immuno-oncology has revolutionized outcomes, but still the TKIs play a role for those patients who can't get IO or in sequence. And we've really seen a change in the natural history of liver cancer. And I think we'll continue to see that as these drugs move to earlier stage. And I want to thank my colleagues at UCLA who have been so supportive. So thank you very much.
All right, we will invite Dr. Mehta to come up. Thank you so much, Drs. Mehta and Finn. We're now going to have an interactive case presentation too, actually, by Dr. Wong. And we'll have, again, interaction with the panelists. And again, these are cases that I think you see every day in your practice. Dr. Wong.
All right. So we'll have two cases that we're going to go through. These are sort of practical cases to sort of put into practice what we learned from Dr. Mehta and Dr. Finn. So the first case, and this to prepare Dr. Mehta, this will primarily be directed for you for most of the questions. But so case one is a 58-year-old African-American man with Hep C-related compensated cirrhosis. Was seen in 2022. No other health issues. Has a supportive family. Achieved SVR in 2016. Has been sober since 2014. Has been getting screening surveillance. Ultrasound showed a small nodular liver with a 2.1 centimeter lesion in the right hepatic lobe. Splenomegaly was seen, but there was no evidence of ascites. These are some of the pertinent laboratory data. As you can see, platelet count 140. You can see some of the other synthetic function. Billy, INR, not bad. EFP of 7. So the first question, Dr. Mehta, what is your next step in thinking about this patient and sort of starting the next diagnostic and perhaps treatment approach?
Yeah, no, it's I think we see this a lot in clinical practice where you have an ultrasound that's positive and we often think about what to do next. So a lot of it depends on the size, I would say. So if there is now we have kind of LIRADs for ultrasound, which is quite nice. And hopefully your ultrasonographers are giving you recommendations on what to do when a lesion like this is seen. But for a 2 centimeter lesion, or even if it was over 1 centimeter, we would certainly do a quad phase, either CT scan of the abdomen or an MRI, I think would be our next step. Some of these other ones may be appropriate down the road, but first thing when you have a positive ultrasound is to get the quad phase imaging. Yeah.
And you really mentioned earlier a little bit about sort of the role of biopsy and for most cases, not really relevant.
Yeah, I think our oncologists are using it more and more, just, in terms of comfortability of treating someone for HCC without a biopsy diagnosis, as well as we're making we're kind of behind all the other cancers in terms of without biopsy, it's harder to do personalized treatment of cancer as well. So I think there's definitely a growing role of biopsy, but we would always get cross-sectional imaging before considering kind of whether a biopsy is necessary. But I would say in most cases, a biopsy is not needed.
Perfect. So this person did undergo a triphase CT abdomen. It confirms a 2.4 centimeter solitary hepatic lesion in the right hepatic lobe. They graded as LIRADS 4, and it showed, some of the text there showed arterial phase enhancement was present. No evidence of delayed washout or pseudocapsule. Again, saw enlarged spleen, no ascites. The CT also showed no lung lesions. So you already walked through this a little bit, but can you walk us through how, specifically for this patient, how did they get to the LIRADS 4?
Yeah, no, exactly. So, we talked about the larger the lesion, the more likely to be HCC. So that's why you see a differential approach to less than 2 and greater than 2, or in the right, less than 1 to 1.9 and 2 or higher. But so we're on the right side here. We have a lesion over 2 centimeters. And so the question is, how many of these other criteria do they have? And so with a lesion over 2 centimeters that's enhancing, you're always either LIRADS 4 or 5. And you actually don't need much to make it a LIRADS 5. You just need one of these other features: washout, capsule, or threshold growth. The patient doesn't have any. And so in that case, we are in the LIRADS 4 category. If they had any of those other 3 categories, other 3 diagnostic criteria, then it would have been a LIRADS 5. So now we're a bit, stuck in terms of what to do. I'm happy to, I don't know if I should kind of comment on what would be next, or if we're gonna, okay, oh, there you go. All right, there you go. Yeah, were you gonna?
Just wanted to ask about the triple panel.
Oh yeah. Yeah. So, would you have gotten it?
Everybody has.
Everybody gets it. That's right. Yeah. So, you'd be doing GALAD for screening, or you would have done it once you have a positive ultrasound, you would have got the biomarkers.
Well, the LIRADS 4, if I've got an AFP of 400, I'm not going to biopsy. If I've got an AFP of 8, biopsy would come into play. Same thing with L3 or DCP. If you look at the numbers.
I think it's important to remember LIRADS 4 is what 80-90%. It's still cancer, right? It's just for so if you're talking about transplant, they're not going to take it, but no one's questioning that this isn't a malignant lesion. I mean, it's very unlikely. The question is, how do you game the system, right, to get them the points or whatever you need, right?
Yeah, and there's a lot of different things to take into account. Definitely, the majority of these lesions end up being HCC, and so I think I think probably a lot of us have seen these abstracts that have come out that the triple panel can be useful for LIRADS 4 lesions, and so I do think, especially with an AP of 7 in this case, getting an L3 and DCP would be one of the options that we probably would do as well. This is hard. I mean, I think there's 3 good options here. Certainly, and I'm not sure all of them are on here, but certainly a biopsy would be okay. If going straight to biopsy is fine, as we said, most of these lesions are HCC, and so we don't want to be delayed for too long. And so upfront liver biopsy, as we definitely want to bring these patients to multidisciplinary tumor board. And biopsy would be one of the 3 things we think about. The other thing we think about is option E, repeating in 2 to 3 months. The patient doesn't have a super high AFP. And so, especially if you got an L3 and DCP that were also low, you might say, okay, it seems like we could wait and figure out which trajectory we're going here. Is the lesion growing or not in 2 to 3 months would be enough time to sort that out. The other thing that we often do would be just to get an alternate modality, I think. If the patient didn't have a reason why they couldn't have an MRI, we probably would actually get an MRI in this case. But I think, D, E, and then F MRI would all be fine options for me. Yeah,
it's interesting because, the guidelines in the past used to say that you need 2 modalities to make the diagnosis, like CT, going back to Jordi Bruges and our friend from Toronto, I forget his, but their initial guidelines,
Sherman.
Yeah, with Morris Sherman, their initial guideline had 2 modalities to make the diagnosis, but I think that should be an option.
And then getting back to what Dr. Gish said, so let's say that they did get additional tumor markers and they were really high. Like how does that play into the decision now for you guys?
Yeah, so or similarly, if the patient's AP was not 7 but 700, so I think the biomarkers can definitely play a role because, as we said, if we're already at a 70% pretest probability of HCC and then those take you up much higher, now you're really thinking, okay, I need to confirm. Do I need to confirm the diagnosis, or, can I just get into the treatment paradigm? So really, it becomes, okay, what is my likely treatment, and then starting to work backwards. So if you're thinking that this is someone you'd be going down the transplant track, well, then a LIRADS-4 isn't enough, right? You have to either, do something else to make sure it's a 5. So that's also doing an MRI or biopsying it. I almost certainly would never, if someone has very high biomarkers, we don't wait for 2 to 3 months, because those are the patients that are gonna really next scan will show badness. And so, so in that case, but in this case, you said the platelet count was 140.
Yeah.
I can't exactly remember where the lesion was, but if I'm thinking about resection, it may, and if you have a, AFP of 400, it's, even though it's LIRADS-4, you might consider just upfront resection and just kind of being done with it, since the pretest probability of malignancy is so high.
Can I ask about contrast enhanced ultrasound? I mean, this person maybe had a pacemaker or some other reason they can't get an MR. Are you all using CEUS at all?
I don't see it at UCLA that much. I think we would probably just repeat a CT in 2 months, because this is a low risk patient, presumably, and not much is going to change.
Yeah, we're pretty similar. We have a few ultrasonographers who are excited about it. And so we do it a little bit, but not much. I think the most common time we use it is if we're trying to confirm macrovascular invasion, and we can't tell if this is kind of portal venous bland or tumor thrombus. We'll sometimes use it because it seems like it can be very helpful in that situation, but we're not using it routinely for diagnostic purposes at UCSF.
Thank you.
Great. So let's see what happened to this patient. So follow up, we got a repeat CT in about 3 months. Another triphase shows a 2.6 centimeter lesion, this time LIRADS-5, and has the characteristics that you mentioned that put in the category of LIRADS-5. Again, you see the labs there, not too different. Platelet 145. The AFP did rise from 7 to 45, but the rest of the synthetic markers are pretty in line from the previous labs that we saw. So then at this point, now what is your next step? Now we had a repeat. Now it's clearly LIRADS-5, AFP bumped to 45. So what are your thoughts about the next approach?
Yeah, this is a multidisciplinary discussion, right? The first thing I would say is this patient is potentially curable, right? So a surgeon needs to weigh in. They're well compensated, no clear portal hypertension. It's gonna be location, can they have surgery? And if they can't have surgery, probably to IR as a bridge to transplant.
Yeah, totally agree. Platelets 145, single lesion, kind of in that, sometimes lesions we think may be too small for resection. Like a lot of centers, if it's under 2 centimeters, doing a kind of a multi-segment resection with higher morbidity may not be appealing. But I think this is like the sweet spot, the 2 to 5 centimeter single lesion, that we would definitely think about resection up front.
Yeah.
I didn't see this, but do we have an endoscopy?
They did have endoscopy, no significant esophageal varices,
So
portal hypertensive gastropathy.
That'd push me more towards surgery with the bilirubin. What's the direct bilirubin?
I don't
I mean, the
know. but
total
the
was like
total's
1.2, was
1.2. Yeah.
1.2 is not normal. 0.7 is normal for total bilirubin.
good
So
enough for me.
I really want to know direct. That's the best liver function test.
It's
We're
true.
moving the bar.
It's true. No, because I actually have a patient who I've been following now with one of our hepatologists who bilirubin came back suddenly at 4.5, right? They're on atezo-bev and I'm all, what's going on? And when we fractionated it, it was actually only like 0.9 direct. So I don't know.
It's important to know.
Yeah.
Direct is the next move we're going.
So this patient unfortunately got lost to follow-up for about 4 months and then represents into care with sudden onset abdominal pain. They had a repeat endoscopy. Again, no varices, some mild portal hypertensive gastropathy. Again, the labs you see here, the AFP is now bumped up to 200. They did repeat a CT. Now the lesion is 5.5 centimeters with evidence of invasion of the right branch of the portal vein. Still no ascites. And then unfortunately now there's a suspicious lesion in the 2 small lung lesions that are suspicious for metastatic.
I want to make one quick comment. you've been describing triphasic CT, but there actually are four-phase CT. That's what Neil said at the original. The triphasic is a misnomer. There's always a non-contrast and then three contrasts in there, just so everybody knows that this is really a quad phase.
Good points. So then now, what do you guys think? This is someone that now represents 5.5 centimeter lesion, concern for possible suspicious lesions in the lung, AFP 200. So what are the potential options now for their approach to therapy?
I mean, what's interesting about this case is this is a very bad tumor, right? And it's bad. It's good they didn't get transplanted, maybe, because look, the patient in 4 months, the tumor developed vascular invasion, liver met or lung metastases. So this is there's something biologically off about this tumor, but we'll never know. But at this point, I mean, this patient is a great candidate for a clinical trial. They're well compensated, measurable disease. They have advanced disease by the Barcelona criteria with vascular invasion, but they also have lung metastases. If they could not qualify for a clinical study, I would argue that atezobev is the most active way to treat them, assuming they don't have high-risk varices. Otherwise, durvalumab would be an option. But this is the type of patient that is, we salivate over to get on clinical trials, because so many patients with liver cancer are not candidates for trials, right? I emphasize that to my colleagues out there. I see a lot of liver cancer, but the percentage of patients that meet trial criteria based on Child-Pugh, platelet count, other comorbidities, whittles down, and we really need to keep up on that.
I want to make one more plug for this biomarker panel. There's really good data in Japan that DCP and L3 correlates with tumor behavior, presence or absence of obviously macrovascular invasion. You can see on imaging, well, moderate, or poorly differentiated tumor and histology. So I think these biomarkers have multiple layers of utility, both for surveillance, risk, and patient management.
I was just gonna maybe ask about the scenario where the vast majority of their tumor, it sounds like, is in the liver, right? So it's 5.5 centimeter tumor, branch, portal vein invasion. If you just said that, you might think about Y90, right? But then you added in these two suspicious small lung lesions. But we often struggle with this. And if 95% of the disease is in the liver, the question is, and we don't have the data yet, but the question also is while you're getting them ready for their clinical trial or their atezobev, is this someone that a one-time Y90 and then straight to GI oncology to start therapy could potentially work? Again, we don't have any data for that, but none of us are going to be surprised in the next few years when combination therapy is better than maybe atezobev alone, for example. So that's one question we might think about, is on the way to the atezobev or the clinical trial, would you do a single Y90?
Yeah.
So I would say no, right? Based on evidence-based medicine, there was this thought with sorafenib Y90, and those studies were negative. It didn't show any benefit, and that was with a very weak anti-cancer drug. Interestingly, and again, things that seem obvious, don't always pan out in medicine, because there's things we don't account for. And there was a very interesting study that's initially came from the Barcelona group, which has repeatedly been validated about sites of progression and prognosis. And you would think that growth in the liver carried a worse prognosis than the development of an extrahepatic site. And it wasn't the case. You could have a large tumor burden, but if you develop a new MET, that patient had a worse prognosis than if someone just had increased growth in the liver. Which is a little, counterintuitive, but I think it just speaks to the tumor biology and things we just don't otherwise measure. Because we've known, with a lot of the TKIs, we improve survival just by slowing progression. And I would argue, and I've discussed this, and again, I can't say I have data, but to get an objective response with a medical treatment probably means a lot different than an objective response with a local treatment, right? And again, I think that portal vein invasion is not just a factor that the tumor's been there long enough, but it's something about its tumor biology. But again, these are hypotheses.
Rich, can I ask you a question about the Y90, the SARA study, the Cervinib study? Everyone keeps calling those studies negative, but they were equivalent studies in terms of sorafenib versus
They weren't
Y90.
equivalent. They were superiority studies that didn't meet their endpoint. So
Right.
they're negative, just like LEAP 002 is negative.
I'm going to say they looked equivalent to me in terms of the outcome with much better tolerated therapy with the Y90. I think sorafenib, I've given it, I don't know, 70, 80 patients, lots of adverse events. You give Y90, get the same outcome as sorafenib.
It's not this. How can you say it's the same outcome?
Same survival.
But there's statistics, right? So the confidence interval on that tells you where, the true survival may be, right? That's the median survival. And those studies were designed to show that Y90 was better than sorafenib, and they weren't. So they're negative. So let me finish. So if I have trying to show that Tylenol is better than, or a new drug is better than Tylenol, and that drug does not meet its endpoint, that drug does not get approved because it was a negative study. So
Does that stop you from using the information in the clinic?
yeah, because it's from the statistics, you can't say that they're equivalent. They're not equivalent. You can't say that. Now, equivalent studies aren't done in clinical trials. We do non-inferiority because it's very hard to show equivalence. Equivalence is used for PK and things like that. Non-inferiority actually says, well, maybe it's actually a little worse, but we're willing to tolerate that. And then there's superiority. So if a study is designed to say something is better than something else, and it doesn't meet that endpoint, then I don't think we can say they're equivalent or better.
Has to do with the choice of designing the study. I got
Yeah.
it. Thank you.
Great. So before moving, the one question to follow up on is you mentioned that, or I guess, where are we in terms of using biopsy? Because you mentioned that this seems like a very aggressive case, but we have biomarkers to some degree, but where are we in terms of using biopsy to characterize HCC to somehow tailor therapy? How far are we away from that?
I mean, it's a good question. And for a long time, we didn't get biopsies. And some people say, well, that's hurt our knowledge base. And it probably has. We have a lot of tissue from resection specimens, which have been used to characterize molecular subgroups, potential targets. The problem in liver cancer, unlike perhaps breast cancer, where we have therapeutics that are clearly linked to molecular tests, estrogen receptor, HER2 receptor, BRCA mutation, et cetera. In liver cancer, for one, there's never been a linkage between a biomarker and a treatment decision. And there's no doubt that commercialization of these tests is critical for uptake. And until it's linked to a decision, it's not going to catch on. And even for prognosis, and again, prognosis, I don't know. I've never been a huge fan of developing just new prognostic factors. I mean, they're important for clinical trial design. But, we know that poorly differentiated probably does worse than well differentiated. And there was a suite of genes that were put together for prognosis post-resection, right? That might be helpful to know who benefits or who needs adjuvant treatment. But for patients with advanced disease, biopsy has not really played a big role.
Perfect. Any final comments? Nice, lively discussion.
I want to ask one more. Richard may know about this, or Neil, and that was in Chicago at ILCA. This is probably 6 or 7 years ago. They were coming out with new PD-1 and new PD-L1 assays, including this Velcro assay, which I thought was exciting just from the name. But why haven't we come up with better tests for PD-1 and PD-L1?
I mean, I think it's because the immune system is so complex, right? I mean, these drugs are interacting at the single checkpoint. They're antibodies, very clean, no doubt what they do. They interrupt PD-1 and PD-L1 interactions. But who benefits and who doesn't, I think, is not only tumor factors, but probably humoral factors. And again, I had 20 minutes to talk about it, but there have been a lot of biomarker work, and it's just not coming up that there's any single one biomarker. there's an inflamed signature based on RNA sequencing. But again, unless you commercialize that, it's never going to be used.
Great. So we'll move on to the second case. So this is a different case. A 60-year-old woman, Hispanic woman, NASH, compensated cirrhosis, has concurrent or comorbid type 2 diabetes, dyslipidemia, BMI 32, no alcohol use. Ultrasound shows small nodular liver and large spleen, no ascites, but it was a suboptimal study due to body habitus. These are the labs: platelets 110, bilirubin 1.5, INR 13, AFP 56. So this is for Dr. Gish. What is your next step? And in particular, how at this point with a suboptimal ultrasound, how do these biomarkers play into your decision in evaluating a patient diagnostically?
Well, it's in my, algorithm, I'm going to get that triple panel while I'm getting the MR. And I definitely favor MR well over CT scan unless there's some reason they can't get an MR. In metabolic liver disease, which this person probably has, MR, I think is quite useful. So triple panel at that time, MR, and then make a decision. Suboptimal is super common, getting more common, unfortunately.
Yeah, I was just gonna, so you said AP was 56, did you,
50.
or something, 50s,
Yeah.
did you put their ALT on there by any chance, or?
Was it on there? No, but let's say it's 40.
Yeah, the other thing I think is one of the reasons why L3 is so nice is because, AP, as we all know, is not a perfect marker by any stretch, and obviously can go up a lot in terms of inflammation. And so we used to see patients all the time who get their Hep C treated and their AFP goes from 100 to 4, or their NASH improves and their AFP goes from high to low. And so, when I'm thinking about someone with an elevated AFP, I immediately look at their ALT, because if their ALT is normal, but their AFP is up, that really is making you think of cancer, versus if their ALT, Hashim and a lot of others have shown nice data on this. But if they have an AFP of 56 and they have an ALT of 150, well, then you're not sure what's going on.
And be careful with DCP with Coumadin.
Okay. So this woman does undergo quad phase CT of the abdomen, has 2 lesions measuring 4 and 3 centimeters left hepatic lobe, was LIRADS 5. It has the characteristics that we reviewed multiple times that makes it consistent with the LIRADS 5. And this one goes for Dr. Finn. So now, based on this patient, what is your approach and what's going through your mind?
Can you just go back?
Oh, sure.
So I have the data there. So 2 lesions, 4 centimeters, 3 centimeters, cancer, confined to the liver. This is Barcelona B, intermediate liver cancer beyond Milan criteria. But clearly within any downstaging criteria, we'd present at tumor board. I mean, conceivably, if they were in, one lobe, maybe the surgeon would resect. But I suspect more likely this patient will get some local regional treatment, Y90, perhaps, given the bias of our interventionalists, and then be listed for transplant.
Perfect. Any other thoughts, Neil or Bob?
No, I totally agree. I would just say with a 4 and a 3 centimeters, likely very, very high risk of recurrence with resection. So transplants is almost certainly her kind of best chance for long-term cure. And, both, it seems like Y90 and TACE would give you relatively high rates of downstaging. Once you're downstage, then you can meet criteria for MELD exception.
And I always look at that scan, both MR and ultrasound. Is this a small liver, normal sized liver also, especially in a metabolic syndrome with a small nodular liver? I'm not going to let the resection team near that patient.
We talked about this already. So we went through the BCLC. Based on this, you talked a little bit about the different options.
Yeah, there's no reason to give this patient medical treatment.
Yeah.
They have no features for that. This patient should be well managed by interventional radiology.
So that was discussed with her. Unfortunately, she does decline to undergo local regional therapy and gets a second opinion for transplant. She was declined by the transplant program, and now she's seeing you for a third opinion. What is the most feasible evidence-based treatment option for this patient?
This patient clearly lives in Los Angeles, where they can get several excellent opinions given what's available. But again, I would encourage this patient. I'd say you have a curable illness, right? That's very lucky. It's not common. We see someone like this. LRT is very well tolerated, and transplants are very appropriate, but it takes 2 years now in Los Angeles, Southern California, in San Francisco probably as well, even with a MELD exception score of 32. And look, I always tell these patients, especially the ones who are concerned about transplant, you have such a long wait time, maybe you won't recur, right? Maybe you will be that patient and then put them on hold, and we just can't predict the future. But for now, you should get LRT.
I remember
Yeah.
the HCC tag. I think Dr. Pillai presented a case where they had pursued at least 3, if not 4 opinions in, I think it was in the New York area, but it might have been Chicago. But there are patients and all 4 opinions were different, as I recall.
Oh, that's interesting. So this person does follow your recommendations. HCC is successfully downstage, and then she undergoes a successful transplant, followed by uneventful recovery. Any final comments on this case?
Yeah, I was just gonna ask. So if we had that last patient who had the 4 and 3 centimeter tumor, and say, so we're struggling with this a bit, but so say you do Y90 but with this 18-month wait, they're going to need multiple treatments. But say you're seeing kind of new spots pop up on every scan, or AFP is rising. We're starting to think about systemic therapy in that setting to maintain target tumor stage and try to, especially if she even had more, if she was the all comers or the beyond, downstaging. Those patients have such poor intention to treat survival that we're trying to do everything we can to try to get them to transplant and have a good outcome after transplant. And so we're starting to wonder, okay, who is that patient that would benefit from systemic therapy while they're on the list? If she was responding well to local regional treatments, it's probably unnecessary, especially for AFPs coming down. But I think there is a select group who probably in the future, a lot of centers will be using systemic therapy on, knowing that you probably need, if you're using immunotherapy, you probably have to have a washout period before transplant. We do 3 months, but I don't know if you guys have kind of started doing this yet.
I mean, you're coming from the mecca of pushing transplant, right? And I have a few comments. One, we're having a hard enough time getting livers for people who are truly appropriate, right? So I always wonder, are we just teasing people by saying, oh, we're going to get you a liver and all that? But to the real medical part of your question, someone who has an aggressive tumor that can't be controlled with LRT, that patient, as you comment, isn't going to do well with transplant. But say you start them on immunotherapy, they have a great response. Does that mean that post-transplant they're going to continue to do well? Or are they just going to explode once they're immunosuppressed? You bring up a very important point that the use of IO is contraindicated. Certainly post-transplant, that has to be done with great caution. But even pre-transplant, there's a potential problem. So I have a lady who we actually fit that criteria, and she's getting atezo-bev. And it's a real challenge because, you don't control when someone gets a transplant. And, now she actually has gotten some MELD exception points, and we're kind of stuck. Her big question is, when are you going to stop? And I said, I'm not sure. We're making it up as we go along. We'll figure it out.
I wanted to emphasize one important issue, and I guess there's a question too. I'm seeing a hand fly.
Oh,
Is there the microphone? Can I grab it? While you're waiting for the mic, I just wanted to emphasize what Richard was talking about in terms of improving survival is integrating hepatology frontline. You treat every patient with hepatitis C as soon as you get the RNA test back. They're on a DAA. You don't wait for them to be downstage or be stabilized. That's fake news when that was published. I'll make that very strong statement. Hepatitis B, they're all on treatment. Metabolic syndrome, aggressive management, alcohol use disorder. You've got them in a multidisciplinary team. You treat the underlying liver disease and they will tolerate these TKIs and systemic therapies much better and live longer. Sorry.
Now we're all just excited to hear what you have to say, Anjana.
Anjana, we're ready.
Sorry. Actually, I wanted to ask you all about what we were discussing. So I have a patient similar that was downstaged on atezo-bev after local regional therapy. and was about 8 months, 6 months of clean scans listed. So we stopped the Tesobev. 3 months later, which is just a scan last week, he has 3 new 1.5 centimeter lesions. So within Milan, was out of downstage before, right? I mean, within Milan now. What would you guys do? He responded to a Tesobev really well, had really clean scans, no lymphadenopathy, nothing. Still a very good Child-Pugh A 5-6. Would you restart a Tesobev, knowing that that makes transplant tricky because how long will I wait now? You know, would you do local regional therapy because it's 3 lesions that are 1.5 centimeters? Would you do a combination or Len or change to Durva, Tremi, or Len?
Yeah, it's an excellent, challenging case. I mean, I don't think this and again, we got to give them the patient the benefit of the doubt, but I don't think this patient is going to do well with transplant. I think it's cosmetic, right? You could do an ablation of these lesions and improve the scan, and maybe they'll get transplanted next week, but there's probably more cooking there, right? And then you'll immunosuppress them. And again, I can't tell you that for sure, but this doesn't, this patient will say, well, I'm in Milan, you're going to transplant me, and you will. But I don't think this patient's going to do well. I mean, how would you justify not transplanting?
I totally agree. Most patients who go to transplant don't have 3 bio, most patients are single, so I totally agree. This is a high risk. I think if you're trying to decide if transplant's still a realistic option, it's unclear how much time they waited and how much, but if you think you're relatively close, that's when we can use things like PET scan. And so there's good data in the live donor transplant population that if you do a PET right before live donor transplant, the intrahepatic PET positivity strongly predicts outcomes. And you have all these biomarkers, right? So this might be a patient that we might, especially if we think they're towards the top, but we're worried about their biology and maybe they're going to have a high risk of recurrence. Well, then you might get a PET, you'll get your AFP, L3, and DCP, and then maybe have enough information to help push you one way or the other. But I wouldn't be surprised with the 3 new lesions if they had a high tumor markers or PET positive. Even and when we talk about PET positive, we're not looking for extrahepatic disease. We're looking for intrahepatic tumor to non-tumor ratio that's over 1.5 or over 2 PET positivity.
See, I don't think you changed the natural history of this tumor, right? You treated them and they responded, and that's fantastic. But it's different when you downstage. Again, difference with response from systemic treatment, local treatment. They just had local treatment and nothing else popped up. That means a lot more to me than getting medical treatment and then you stop it and they come back, right? But PET's only positive in like 2/3 of patients, right?
Exactly. So I think it's trying to give us more use information to like reassure us that because most patients don't recur, right, with transplant. And so if you have all your biomarkers negative and you have a negative PET, that's there's data out of India that when they have that, even if they're beyond UCSF expanded criteria, they do quite well with live donor transplant. So I think probably the risk of recurrence would be a little bit higher than that 10% usual, but they may do okay. And obviously it'd be, a curative option that otherwise they wouldn't have. So I agree that I'd be skeptical, but cautiously kind of hopeful that if their PET's negative, that maybe they have some access to an offer, live donor or somehow expanded criteria or expanded donor, something like that might be okay.
Great. We have some questions here.
Yeah, so you may have just answered the question I was about to ask, which is to take your patient that you just presented on the slides. At what point in this pathway do you introduce live donor?
Yeah, so we introduce it fairly early just because, our wait times are so long and the patients have already need to get downstage to start accruing. And so there's already built in kind of time. And so we bring it in fairly early to the discussion. You don't have to be within Milan to get to, right? You don't need medical exception anymore, though typically most places are still in the US kind of trying to downstage patients because we know that response to local regional therapy is such a powerful prognostic marker. But if once someone is downstage, especially and they have a live donor, we'll typically still wait 3 months just to make sure that they don't have super aggressive disease. But pretty early, we're willing to think about live donor transplant.
So this is Paris Mantry. think the field of transplant oncology obviously is complicated, chaotic, and obviously with all the new therapies that we've had with Y90, IOs, response rates, and we do a lot of downsizing as well. My question and comment was about, using the tool of molecular residual disease, which we've started doing. I think we're going to present this as an oral at an upcoming meeting. What do you have any thoughts or comments on measuring molecular residual disease after transplant with circulating tumor DNA for some of these high risk individuals? And if you find it, would you consider the role of any adjuvant therapy after transplantation? Because it looks like both your centers certainly do high risk patients that are downstage, but we don't have full time to understand the complete tumor biology.
So you bring up some very topical issues. There's several assays, some of them commercialized, for detecting minimal residual disease and adjuvant breast cancer or colon cancer, using very sensitive, looking for circulating tumor DNA. And some of them have been predicting early response. In those diseases, it's not clear what you do about that yet, right? Do you start treatment even though the scans don't show anything, or is it just anxiety provoking? Vache Agopian, our surgeon at UCLA, has very interesting NIH-funded studies using a different type of a technology at transplant, pre-transplant, to predict who might relapse after transplant, right? I mean, instead of just using, if you think about it, we use imaging, which is a pretty crude measurement, right? And maybe that will eventually pan out. I think to your question about adjuvant treatment, someone has a transplant and then we detect tumor DNA, we do scans and it's negative. I mean, it's hard for me to just start someone on a treatment, no matter what it is. It has some toxicity, whether financial or physical, unless we see something on a scan. It's similar. Some patients post-transplant have a rising AFP, right? We scan them, there's nothing there. And certainly there's smoke, but I personally don't start them on treatment. I say people don't die of a high AFP, they die of a tumor that's causing problems. I think we're just not there yet, but it certainly is an important question.
Yeah, the other, added piece to that is that even if you wanted to treat them, you can't use your IO therapy. And so now, so we definitely wait to actually see imaging detection of tumor. The other thing we would consider doing is switching our patients with high risk for recurrence after transplant. We'll switch them to mTOR-based immunosuppression relatively early on in their post-transplant course, usually about 4 to 6 weeks. But a lot of times that's 4 to 6 weeks. Like that's a little bit later in the course, right? If you think that someone's going to have recurrence, a lot of times that's from circulating tumor cells at the time of transplant. So other centers have looked at kind of immediate mTOR switch. There is this black box warning on wound healing and stuff, but we typically wait 4 to 6 weeks. There's been a nice trial, the Silver trial, that compared mTOR-based immunosuppression, and there was a sort of overall survival and recurrence-free survival improvement for about 3 to 4 years after transplant, but then it went away at 5 years and beyond. So mTOR-based immunosuppression is something that you might consider if someone's at high risk for recurrence after transplant.
Any other questions? Dr. Flam, you want to make some closing comments?
All right, I'd like to thank the few hardy souls that actually remained to overtime here. I'd like to thank our panelists. Excellent presentations and conversation. Hope you found it helpful. On behalf of the Chronic Liver Disease Foundation, I'm again very thankful that you guys came to our session today on HCC and to the entire Liver Connect.